Welcome to the third part of our CNS infection lectures. Today we are going to talk about the brain abscess and their mycobacterial infections. I am Dr. Carlo Magno Alejandrino and we will begin shortly. A brain abscess is a focal suppurative infection within the brain parenchyma, typically surrounded by a well-vascularized capsule. It can arise from direct extension, hematogenous dissemination, or post-surgical infection. Early diagnosis and management are crucial to prevent neurological deterioration, radiation, or death. Again, your bacteria can reach the brain through contagious spread, direct extension from infections in the adjacent structures. Your sinusitis, otitis media, mastoiditis will cause abscesses in frontal and temporal lobes. Dental infections may also cause an abscess in the frontal lobe. It can also reach the brain through hematogenous dissemination, through bacteremia or septic Ebola. Your infective endocarditis, pulmonary infections causing lung abscesses and bronchiectasis may facilitate bacteremia. Also, cases of cyanotic congenital heart disease, such as her tetralogy of Fallot, may cause septic emboli as well. Post-traumatic or post-surgical infections may also be the reason why infections will reach your brain. Penetrating head trauma, neurosurgical procedures, or contaminated implants can be the cause for your CNS infection. So once an infection establishes itself in the brain, it progresses through four stages. Early cerebritis phase occurs during the first 3 days, where you can have local inflammation and edema. Late cerebritis, occurring during days 4 to 9, is where necrosis begins and macrophage infiltration happens. Early encapsulation is when fibroblasts start to form the affected capsule, and mature abscesses, usually more than 14 days, appear with thick fibrotic walls. The causative organisms depend on the source of infection. If it comes from your nose or your ears or your sinuses, Streptococcus, Staphylococcus, and Haemophilus bacteriae are common. Anaerobes may also be present, such as Bacteroides and Fusobacteria. If you're looking at hematogenous spread, Staph aureus, Strep viridans, and Nocardia are your usual culprits. Post-neurological or trauma-related abscesses are usually caused by Staphylococcal aureus, Pseudomonas, and Enterobacteriaceae. Immunocompromised patients usually suffer from Toxoplasma, Aspergillus, and Cryptococcus. The presentation of brain abscess varies depending on the location, size, and the stage. Classic features will include headache, which is the most common symptom present in 70% of cases. Your patient may also have focal neurologic deficits. Around 50 to 65% of them will have focal neurologic deficits, and the manifestation will depend on the lesion location. So if you have a frontal lobe abscess, you may have personality changes, hemiparesis. You may have aphasia and visual field defects if you have a temporal lobe abscess. And cerebellar abscesses may present as ataxia, dysmetria, and imbalance. Fever is present in 45 to 53% of cases. Often it's absent in chronic abscesses already. Seizures is 25 35%. And signs of increased intracranial pressure, such as nausea, vomiting, papilledema, altered mental status, drowsiness, or coma. Brain abscesses must be distinguished from tumors, subdural empyema, encephalitis, and stroke. How do we diagnose an abscess? Sometimes you can already see them through imaging studies. MRI with contrast is the gold standard, and it shows ring enhancing lesions with central necrosis. CT scan is an alternative if MRI is unavailable, and it shows hypodense center with peripheral ring enhancement. In MRI, we are looking at the diffusion-weighted imaging, which helps differentiate abscess from tumors. Laboratory tests, such as your inflammatory markers, will be elevated, and blood cultures will be useful if we are looking at hematogenous spread of your infection. Lumbar puncture is generally contraindicated due to the risk of herniation due to elevated ICP, and stereotactic aspiration or biopsy may provide definitive diagnosis to identify the causative organism and guide treated antibiotic therapy. So we are presented here with an MRI of a patient who is suffering a cerebral abscess on the left frontal lobe. We can see the hyper-intense capsule here in T1, hypo-intense capsule here in T2, and rim enhancement on gadolinium contrast study. We can also see some vasogenic edema here, especially on the T2, and it has restricted diffusion, as we can see here in the hyperintensity, in the DWI corresponding to the hypointensity here in the ABC. Your perfusion-weighted imaging also shows no evidence of increased perfusion in the gadolinium enhancing group. Remember, even before any laboratory tests, we need to start the patient immediately on empiric antibiotic therapy. For unknown source, our standard regimen includes your ceftriaxone, metronidazole, and vancomycin for 6 to 8 weeks IV, and then shift to oral after 4 to 6 more weeks of treatment. If it's post-neurosurgical, we will cover with cefepime or meropenem and vancomycin. If it's a fungal abscess, we start with amphotericin B and voriconazole. Neurosurgical intervention may be useful. We can aspirate or drain via stereotactic needle or open craniotomy, usually only if the abscess is more than 2.5 centimeters or if it is causing significant mass effect or impending herniation. We can also do surgical excision if there is failure to improve with antibiotics. Of course, let's not forget your supportive therapy, including your seizure prophylaxis, ICP management, and close monitoring in your critical care settings. With early treatment, mortality is 10 to 20%, but neurological sequelae can occur in 30% of survivors. Potential complications include your herniation, ventriculitis or rupture into the ventricles, which produces a poor prognosis, and epilepsy, which is a long-term risk, particularly in vertical abscesses. Again, to prevent this, early treatment of sinus, dental, and ear infections, antibiotic prophylaxis in neurosurgical procedures, and prompt evaluation of patients with immunosuppression and new neurologic symptoms. That's it for your brain abscesses. And now we'll go to your Mycobacterium tuberculosis infections. So the global burden of TB remains to be a major public health concern. It is closely linked to poverty and marginalization, and the WHO estimates about 25% of the global population is infected with tuberculosis. TB has dropped from 7th to 13th among leading global causes of death, but despite a decline in TB deaths, progress is too slow to meet WHO's end TB strategy goals. So 90% of TB cases affect adults, and men are more commonly affected than women. Pulmonary TB is around 85.67% of all TB cases, while extrapulmonary TB is 14.75%, with CNS TB being the most severe. CNS TB prevalence is 2 to 15% of extrapulmonary TB cases. It is more common in AIDS patients, and CNS TB is more common in females as well. 60% to 70% of cases occur in those under 20 years old, and peak incidence is in children under 5 years, though rare in infants under 3 months. Risk factors include your HIV, diabetes, malnutrition, chronic renal failure, cancer, chemotherapy, and patients who are on immunosuppressive drugs. Mortality rates is 42.2% in children under 13 years and 2.7% in adults. Tuberculous meningitis occurs by pathogenous dissemination from a primary pulmonary focus or reactivation of latent Mycobacterium tuberculosis within the CNS. The bacteria seed the meninges and brain parenchyma, forming rich foci, which may later rupture into the subarachnoid space, triggering a chronic inflammatory reaction. The pathological findings include thick gelatinous exudate at the base of the brain. It may have cranial nerve involvement, especially cranial nerves 3 and 6. Basal meningeal enhancement can be seen on imaging as well, and patients may sometimes produce tuberculomas or granulomatous masses in the brain tissue. So there are three phases of clinical presentation. You have your prodromal phase, meningitic phase, and the paralytic phase. Prodromal phase is the early stage, usually around 1 to 3 weeks. Symptoms include low-grade fever, malaise, headache, personality changes, and the onset is insidious and gradual. The meningitic phase includes severe headache, vomiting, meningismus or stiff neck stiffness, lethargy, confusion. Cranial nerve involvement may also be noted, and long track signs such as weakness, hyperreflexia will begin manifesting during the meningitic phase. For the paralytic phase, it is severe and life-threatening. Confusion may progress to stupor, seizures, and coma. Patients may present with hemiparesis, and there is high mortality if untreated, and death often follows within 5 to 8 weeks. So the classic CSF findings for tuberculous meningitis, you have elevated WBCs with lymphocytic predominance, low glucose, and high proteins. Definitive diagnosis requires identifying Mycobacterium tuberculosis in CSF. What are the challenges in diagnosis? Your AFB smear has variable sensitivity. CSF cultures, although they are the gold standards, may take 6 to 8 weeks with 40 to 83% positivity rate. Multiple large volume spinal taps can increase culture sensitivity to as much as more than 85%. And PCR-based tests, such as your GeneXpert Ultra, may offer faster results, but they have variable accuracy. So this is a patient with an MRI with and without contrast. So the first one has no contrast, and we can see the basal enhancement, and your temporal horns are already open. So for a normal adult, this should be closed. So for this patient, it's already open, signifying your hydrocephalus. The contrast-enhanced CT demonstrates an intense enhancement of the basal meninges, and note the widening temporal horns as well too. Luckily, treatment for tuberculous meningitis or tuberculous infections is readily available in our country. For the intensive phase, you have your isoniazid, rifampicin, pyrazinamide, streptomycin combination to be given for the first 2 months, and you will continue with isoniazid and rifampicin for the next 7 to 10 months. So at least 9 to 12 months total of treatment. For patients who have drug-resistant TB, you may give rifampicin, ethambutol, pyrazinamide, and fluoroquinolone for 18 to 24 months. Pediatric patients will receive rifampicin, pyrazinamide, and aminoglycoside or ethionamide. And corticosteroids have a role to reduce mortality but not the neurologic disability. So it is given usually 4 weeks IV and then 4 weeks oral. So 8 weeks in total. The deadliest form of Mycobacterium tuberculosis infection is your tuberculous meningitis, with a mortality rate of up to 20 to 67% with treatment and fatal if untreated. High-risk groups include your extremes of age, your infants and your elderly, and HIV co-infected patients. Key prognostic factors include your neurologic status at presentation, so early treatment improves your outcomes, and development of hydrocephalus. Once you have hydrocephalus, your prognosis worsens even with surgery. The neurologic sequelae may persist even after treatment. Huh? So your complications include hydrocephalus, hyponatremia in 40 to 50% of your cases, tuberculosis, vasculitis, and stroke in 15 to 57% of patients, seizures, vision loss, and you may also have transverse myelitis. Tuberculous granulomatous mass lesions in the brain, called tuberculoma, may be due to chronic Mycobacterium tuberculosis infection. It develops in 1 in 300 untreated pulmonary TB cases. And 50% of disseminated TB cases involve the brain. 25 to 30% of CNS TB cases occur without pulmonary TB. And in TB endemic areas, 50% of intracranial masses are tuberculomas. So this is an MRI of a patient with tuberculomas. You can see ring enhancing lesions which may mimic abscesses or tumors. And the CSF analysis usually is normal unless it is already coexisting with TB meningitis. So this one is an HLT2 weighted MR image demonstrating hypointense subcortical lesion. So there is the hypointense subcortical lesion within the right parietal lobe with surrounding edema. In letter B, we have the HL contrast enhanced T1 MR image at a slightly lower level, revealing associated chirae form meningeal enhancement as well. Okay? Like your TB meningitis, treatment includes 12 months of HRZ therapy. Corticosteroids is significant if you have mass effect, and surgical resection if hydrocephalus or brainstem compression starts to occur. You may also have spinal tuberculosis or Pott's disease. Extrapulmonary TB accounts for 3% of all TB cases, with 10% of extrapulmonary TB cases involving the skeletal tuberculosis. Spinal TB makes up of 50% of all skeletal TB infections, and in 2016, the WHO reported 10.4 million new cases of TB, with 46.5% occurring in the Southeast Asian region alone. India contributed 23% of the global TB burden, and global migration increased from 173 million to 244 million between 2000 and 2015, leading to a resurgence of TB in developed countries. Spinal TB may result from hematogenous spread of the Mycobacterium tuberculosis, typically from a primary infection, most often in the lungs. The paradiscal region is the most commonly affected area due to the blood supply from paradiscal vessels to the subchondral bone. Other patterns of involvement may include central, which is the vertebral body involvement, posterior, affecting the posterior spinal structures, and non-osseous, which is formation of your abscesses. Progressive vertebral destruction can lead to kyphotic deformity and spinal instability. Chronic back pain is one of the most common symptoms in patients with spinal tuberculosis or Pott's disease. Neurological deficits if the spinal cord compression starts to develop, and you may have constitutional TB symptoms such as fever, weight loss, and night sweat. Gold standard is still culture of your Mycobacterium tuberculosis, but it has low sensitivity due to slow growth. Alternative diagnostic methods include histopathologies, acid-fast bacilli staining, serological inflammatory markers, immunological, and molecular diagnostic tests. Diagnosis is often based on a combination of clinical, radiologic, and laboratory evidence. So X-ray may have limited role in the early stage, and in the late stage, disc space narrowing may be noted, and plate erosion, vertebral destruction, and spinal deformity. It is widely available and useful for detecting advanced diseases, and chest X-ray also helps us identify pulmonary disease. Its limitations include low sensitivity, especially in the early disease, and it cannot detect soft tissue involvement. CT scan is 100% sensitive. It detects fragmentary, osteolytic, subperiosteal, and sclerotic lesions, and it is useful for image-guided biopsy. Advantages include that it can identify bone destruction earlier than your X-ray, and it can provide detailed bone imaging. Of course, again, it is limited in assessing soft tissues, and MRI has a sensitivity of 100% and 80% specificity. It is the best modality for soft tissues, abscesses, and spinal cord compromise. Gadolinium enhanced MRI or contrast enhanced MRI adds diagnostic value. Key findings may include subligamentous collection, para-prevertebral abscess, spared disc space, heterogeneous vertebral enhancement, and it's best for diagnosing spinal TB. It can identify non-contiguous vertebral involvement as well, but it is expensive and it's less available and requires contrast for enhanced imaging. Nuclear imaging can also be used to detect functional inflammatory activity in the spine, and it helps identify active infection sites. Usually, it is used for monitoring disease activity, but it cannot differentiate TB from malignancy or pyogenic infections. Spinal TB is classified as complicated or uncomplicated. Uncomplicated cases are managed with medication alone, And complicated cases, those with neurologic deficits, deformities, or instability, may require surgical intervention along with medications. Medical management includes your HRZE, which is a mainstay of therapy. WHO recommends 6 months of HRZE, and some other guidelines may suggest 9 to 12 months also. Surgical management is indicated for failure of medications, recurrent disease, severe or progressive neurological deficits, deformity, or 60-degree angle of your kyphosis, and severe pain or spinal instability. Your hypotheses have four radiologic staging. Um, First stage is your pre-destructive stage, which shows early signs like muscle spasm and hyperemia on CT scan. Disc space narrowing, paradiscal erosion, and mild vertebral collapse signifies your early destructive stage. If you have mild kyphosis, 2 to 3 vertebrae are already involved, and kyphosis is 10 to 30 degrees. Moderate kyphosis involves 30 to 60%, 30 to 60 degrees, and severe kyphosis involves more than 3 vertebrae, and your kyphosis is more than 60. So as we can see here, this is an MRI of your spinal cord. So you have hyperintensities in this region already, and you have spinal cord compression at this level. As we can see here, there is destruction of your paravertebral structures. For spinal tuberculosis, have better prognosis in early diagnosis and treatment. Complicated TB has worse prognosis than uncomplicated cases. Poor prognostic factors include your age extremes, immune deficiency, and poor compliance or intolerance to your mycobacterial treatment. Okay, so now we go to the CNS infections caused by rapidly growing mycobacteria. Rapidly growing mycobacteria, or RGM, are non-tuberculous mycobacteria capable of causing CNS infections, particularly in the immunocompromised patients and following your surgical procedures or trauma. Common pathogens include your Mycobacterium abscessus, Mycobacterium cedonae, Mycobacterium fortuitu. Direct inoculation, hematogenous spread, and association with medical devices are the usual culprits. They may present with chronic meningitis, having headache, fever, and cranial neuropathies, and brain abscess formation is also part of the clinical presentation. Patient may also develop ventriculitis, especially those with CSF shunts. Your CSF picture will show mild lymphocytic pleocytosis, elevated protein, normal to low glucose. AFB stain and culture will have low sensitivity and requires prolonged incubation. Molecular testing is useful for mycobacteria. Treatment is a combination of antibiotic therapy, macrolides, aminoglycosides, and fluoroquinolones. Surgical drainage of abscess or removal of infected implants, and prolonged therapy for 4 to 6 months to prevent relapse. And that's the end of our CNS lectures. If you have any other questions, feel free to reach out. Thank you.